Welcome. Let's talk about weaning off APRV or airway pressure release ventilation. Now, throughout the ventilation, the goal should be a PaO2 above 55, that's O, and above a SpO2 or saturation of above 88%. Now, once you wean down the FiO2 to around 50%, at that point, that's when I consider weaning the patient down with the P high being reduced. Now, the general recommendation is to reduce P high by 1 to 2 centimeters of water and gradually watching what the SATs change like. And watch the SATs over a period of 20 to 30 minutes. And if you don't see a significant change, or if the SATs are still above the SpO2 of 88%, you can continue weaning that down by 1 to 2. You can continue doing this until you hit a pressure of around, or P high of around 18 to 20. At that point, you can either switch over to volume control ventilation or pressure control ventilation, but be aware that you want to keep the PEEP on those levels at around 14 to 16. That way at least you don't, or you avoid a de-recruitment, too sudden a de-recruitment of the lung. The whole idea of APRV is to keep the lungs recruited as much as possible, and when you slowly bring down the P high, you are compromising a little bit more of the lung recruitment, but because the lungs are apparently healing, they may be able to maintain their recruitment on their own, especially with the spontaneous respiratory efforts that is common in APRV. So while you're doing this as well, it's important for you to reduce sedation or minimize sedation to allow for spontaneous respiratory efforts. Another more gradual approach is something called the drop and stretch method. So what you end up doing is you actually drop the P high and you increase the T high. So what you end up doing is this: the P high will go down by 1 to 2, and every time you go down the P high, the T high then should be lengthened from, let's say, 6 seconds to 6.5 to 7 seconds, for example. So you can increase the T high by 0.5 to 1 second. So what you end up doing is, though you're reducing the P high, gradually de-recruiting the lung, you're maintaining it at that higher level pressure a little bit longer. So it's more of a gradual stepwise approach compared to the initial approach I suggested. Alternatively, as mentioned earlier about switching over from when you have a P high of 18 to 20, you can also continue them on the APRV all the way down to a P high of a bit less, well, of around 10 or even less than 10. So you keep bringing down the P high, keep stretching out the T high, or the drop and stretch method. Once the P high reaches around 10 or so, you may want to go ahead and extubate these patients directly instead of switching them over to volume control ventilation or pressure control ventilation. So definitely I think there's a lot of benefits to the drop and stretch method. But again, I want to just re-emphasize that in the APRV, the whole idea is to minimize the amount of sedation so patients can actually mount their own spontaneous respiratory effort. So even though you're dropping the P high and stretching out the T high, there may be a risk of CO2 elevation due to hypercapnia, resulting in hypercapnia. You can minimize that effect by allowing patients to take their own respiratory breaths. So in conclusion, once you've hit the PaO2 goal rate of 55 and above, and the SATs of above 88%, and the FiO2 is at 50% or below, you want to start bringing down the P high, reducing it by 1 to 2 until you hit a goal rate of around 18 to 20. At that point, you have two choices. Either you go down the route of volume control ventilation or pressure control ventilation. Alternatively, you can keep bringing that down to a value of less than 10 on the P high and extubate the patient when appropriate. The drop and stretch method as well is a common method that's used, and that's when you decrease your T high by 0.5 to 1 second while decreasing your P high or pressure high by 1 to 2 centimeters of water. Thank you.